Tell us a little bit kind of about your background and then
Okay.
about what you're doing now.
Yeah, great. Thanks. So Steve Higgins, and I am a professor here at the University of Vermont, primary appointment in Department of Psychiatry, but also have an appointment in Department of Psychological Science. My research is probably best characterized in a framework of the behavioral pharmacology, behavioral economics of addictions. One of the things that I'm well known for is back when cocaine use was an epidemic in the United States in the late 1980s and early 1990s, it was particularly acute and a major national problem. There was no intervention for it. And so when I looked at the problem and thought about it in terms of what we know about behavior analytic terms, I proposed a treatment based on those principles, and it's come to be known as the CRA plus vouchers intervention. And it turned out to be an effective intervention for cocaine dependence. And it remains to this day, 30 years later, after we started that work, as the intervention that produces the best outcomes and the most best sustained outcomes in terms of behavior change. So, and it truly was just applying the principles of behavior to what we knew about cocaine use from the little bit of literature there was, and how you could extend that to naturalistic settings and treatment interventions.
About that.
Yeah.
So what would you say to behavior analysts who were interested in this field, who were interested in learning more and getting more into this side of things, treatment? What would you recommend for them?
Yeah, I would encourage them to first of all, to learn their behavioral principles very well, and to especially, the extension to understanding human behavior in naturalistic settings, have fun with it. In graduate school, I went to graduate school with a couple people who also pursued addiction, Warren Bickel and Ken Silverman. And we had a lot of fun while we were in graduate school, just trying to always interpret everyday behavior in terms of the principles of behavior, giving each other, we would do it back and forth and argue, but we learned a lot. And we've all had successful careers in extending that work now into the field of addiction. So
Well, this is wonderful. I don't want to take up too much of your time, but I thank you so much.
Oh, I thank you for doing it. First of all, we have a postdoctoral training program here at the University of Vermont.
Thank you. I appreciate it.
All right. Thank you.
You take care.
Bye-bye. Nice meeting you.
Nice meeting you. Dr. Higgins, if you would please introduce yourself and tell us a little bit kind of about your background and then about what you're doing now.
Yeah, great. Thanks. So Steve Higgins, and I am a professor here at the University of Vermont, primary appointment in Department of Psychiatry, but also have an appointment in Department of Psychological Science. And I have been here since 1986, so I believe that's year 37. And my research is probably best characterized in a framework of the behavioral pharmacology, behavioral economics of addictions. And we're particularly interested in certain vulnerable populations, people who have socioeconomic disadvantage, people who have maybe certain psychiatric conditions that might make them especially vulnerable to various use of various substances and becoming addicted to those substances. And my training was, I got my PhD in behavior analysis at the University of Kansas back in 1983. And from there, I went and did a postdoctoral fellowship at Johns Hopkins in the Department of Psychiatry and Behavioral Science. The unit is the Behavioral Pharmacology Research Unit, and that's a group that's very behaviorally oriented. And so the training that I had at University of Kansas lent itself very well to the framework they work within. And then they turned me on to the pharmacology side and how it relates, how the principles of behavior and can be applied to studying the pharmacology of addictive drugs, and how you can do more basic mechanistic kind of research or intervention research. And I have spent the rest of my career doing that.
It was so interesting. That's great. Now, would you consider yourself a behavior analyst or a psychologist? What would you call yourself if you were looking?
Well, it depends who I'm speaking to.
Gotcha.
But I remain a
Excellent.
Behavior analyst. Yeah, absolutely. The principles of behavior, as we understand them, the principles of conditioning and learning, have been at the forefront of everything I've done in my career. And what I learned is that our training and understanding of those principles and how they play out in everyday life can position us to make important contributions. And in my area, it's in understanding addiction and how to change addictive behavior. And it's, I believe it's been the foundation. I think it's pretty straightforward. One of the things that I'm well known for is back when cocaine use was an epidemic in the United States in the late 1980s and early 1990s. It was particularly acute and a major national problem. There was no intervention for it. And so when I looked at the problem and thought about it in terms of what we know about behavior analytic terms, I proposed a treatment based on those principles, and it's come to be known as the CRA plus vouchers intervention. And it turned out to be an effective intervention for cocaine dependence. And it remains to this day, 30 years later, after we started that work, as the intervention that produces the best outcomes and the most best sustained outcomes in terms of behavior change. So, and it truly was just applying the principles of behavior to what we knew about cocaine use from the little bit of literature there was, and how you could extend that to naturalistic settings and treatment interventions.
Yeah, it's funny when you say that, because it sounds like, oh, it's the natural progression. Of course, you would apply these behavioral principles. But just as an aside, so I teach a class of ethics at Mary Baldwin to behavior analysts. Yeah. And one of the articles that we study is the tap-in article. And I think I'm going to move it to yours, because it would probably make a little more sense. The tap-in article from about smoking cessation in pregnant women using contingency management. And then I have them do a discussion board. And my question for them is, what did you think about contingency management before as a practice for substance abuse? And what do you think about it now? And so many are like, oh, it's a terrible idea. We shouldn't pay people. We shouldn't,
Right. Yeah.
But I'm like, read the thing, we've got a problem we can't solve. Look what's going on here. We're now solving the problem. How is that not better?
Yeah. Well, I encourage you. We published this year a paper in preventive medicine on that very topic. So tap-in.
Tap-in's too old. I think I need to move on.
Yeah. So, and tap-in's intervention is just an extension of what we first developed with cocaine-dependent people, but then later extended to pregnant women. And what tap-in did was show that you can do it in a more conventional community setting, which was an important contribution. I love that article. I know which one you mean, but they decrease the frequency that we reinforce the behavior. They decrease the magnitude of the reinforcement, all of which the tap-in is a pediatrician, so a physician. It was all with an idea towards dissemination and what might be fundable, which is good. I tend not to think so much. I think about effect size and how to get the largest number of women to quit, that sort of thing. But the paper that I just mentioned to you includes birth outcomes, and we show that we're changing the likelihood of having low birth weight. It's actually birth retardation, growth retardation, which is one of the main adverse effects of smoke exposure in utero. And we show through this intervention that you can decrease the rate of it's called small for gestational age growth. So so I encourage you to more recently. Tap-in knows about the paper, and he and I end up as reviewers on each other's papers.
I'm sure.
But I think your students may enjoy the paper. And then what we do as well is look at the external validity. So we in collaboration with the Vermont Department of Health, we look at smoking status among all women who delivered babies in Vermont during the year of 2019. And we get the women who never smoked, the women who smoked but quit before the third trimester, just however they quit, and then the women who smoked through the pregnancy. And we show that the changes that we were producing with contingency management and the small for gestational age outcomes is the same outcome you see in the naturalistic setting with moms quitting however they quit. You get the same effect. So it's nothing specific about contingency management that produces the change in the rate of small for gestational age deliveries. It's that you can get them to quit.
Right.
And
that you can get them to actually do it.
Devices, too few of them quit, and that's why it's a problem. But it shows the sort of the external validity of the intervention. The generality of it. So I think your students might enjoy the paper. They may still say the same thing about it's a bad idea, but you can counter that with arguments.
Yeah. I'm just amazed by people when they say, and I'm like, I hope you learn a little bit more about contingency management and see that.
Well, this will be, I'm going to offer another one because tap-in has the same feature, but we have a cost effectiveness. We have a second paper in preventive medicine as well that analyzes the cost effectiveness of the intervention, and it's cost effective. So there's just a very practical counter to the argument this is a terrible idea. It actually, when you see what the benefit is in terms of protecting the fetus and increasing the number of women who are putting down cigarettes, that it's actually cost effective.
Well, it's interesting that I get two arguments, and one is that, it costs so much. And two is kind of the moral of, I don't think they should get a benefit for having smoked and, But my retort back is, but it's not working. we need something that works because this is a
that's
big
right.
problem. Like, we got to go where it's work. It's often what I say to my parents, the ones that I work with, in therapy. I'm like, well, how's that working for you?
Yeah,
If it's
yeah.
not working, we've got to do something else that does work. I'm gonna hit you up for those articles maybe after.
Wonderful. Yeah.
So back to what we're doing there. You mentioned preventative medicine for both of these articles.
Right.
Is that where you generally publish? Do you find that it's important to publish to a lot of different types of, why do you choose what you choose to publish?
No, absolutely. So I am looking for, a broad audience in the field in which I'm working. So, preventive medicine, the journal, the JAMA Psychiatry. So JAMA is Journal of the American Medical Association, and psychiatry is one of the divisions that they have a journal in. So we publish there. We publish in a journal called Addiction. But what's important, I think, is that for behavior analysts to recognize they have important contributions to make, but you're only going to make them as if you get a seat at the table where the disorders or the problems or whatever it is are being discussed. So, I strongly encourage people to try and publish in mainstream journals. And, what you find is that the designs that we typically are, using
Single
and
subject,
comfortable with, small n within subject designs, they can be they can cut mustard in some of these same journals, but what's more likely is you realize that you can stay true to the principles using other kinds of designs as well. We often in clinical trials, we use parallel groups designs, and I've not had any trouble making the translation. And it's, if we want larger groups to accept our approach, we have to understand what the rules of evidence are and show that our principles are sufficiently robust that they can be validated using, the larger audience's rules of evidence. So I think that's an important thing for people to think about. And if we stay too insular and only report in our own journals and whatnot, the larger audience doesn't know about them. And the contribution that we can make is kind of overlooked. So,
yeah, that was a big discussion actually that we've been having recently on the teaching behavior analysis listserv as to whether, and all of those have been coming up. I think a couple of the salient points that we thought were good, we're looking at, well, what is it you're studying? Because that's what lends itself to, does it need to be a randomized control or does it need to be a small n? And it really depends on what you're studying. But if you keep it in mind, like, I'm going to do a small n study, then that doesn't help you. You have to think about what is it I'm studying? What is what I'm studying lend itself to work?
Yeah, I agree with you completely. And, certainly I've done my share of small n studies, including on the topic that I end up doing a clinical trial. So in our seminal work on, which were our seminal clinical intervention work on cocaine, we had parallel laboratory studies isolating the basic principle that you can, by offering alternative monetary reinforcement, you can get people, depending on the magnitude of the reinforcement and the dose of cocaine, you can shift people's choices away from cocaine. So what we showed in the within subjects, small n, I think we had an n of 10 or maybe even 5, but the effects were very robust. So you start off by offering small doses of active cocaine or placebo cocaine for intranasal use to people who already use cocaine, so we're not introducing anybody to the drug. And then And then we show that you give them a maximum of 10 choices, and they can select whichever one they want. All they know is it's lines A or lines B, and these are little lines of cocaine. And so these are experienced users. They have sampled A and B in separate sessions before we give them the choice test. Mm-hmm. And then they take all 10 choices. They allocate all 10 choices to the active drug. They don't want placebo. They want the drug that gets them high. So then you have that. So it's very robust. 10 to the active condition drug, and 0 to the placebo. So that's kind of a laboratory model of what cocaine use looks like, cocaine dependence looks like. Everything being allocated to the drug, nothing allocated to other options. So think of that as a model.
Matching model.
Then what we show, the placebo is out of the picture now, and we replace it with varying amounts of money. You put 0 money in there, you get the same thing as you got with placebo. But as you increase the value of choosing the other option, you watch the choices shift, until you get I think it was $1 or $2 per choice for the monetary option, and you get no cocaine use. And so people would say, well, that's fine. It's in a laboratory. They would make fun of it, that they probably take that money and they go out and buy cocaine. Mm-hmm. But then we show them that now in a clinical setting, you can give people who have been using cocaine in the community and are having a lot of problems with it, they come in, and you can offer them the option, if you come in and show us with a urine specimen that you haven't used cocaine, we'll give you these vouchers exchangeable for retail items. And so that's a choice. They could continue using the drug on the street, but they could not go. If they could forgo use and come in and show us give us a negative urine, and then they get the voucher. And we show that if you compare the same, randomly assigned people with cocaine who are dependents who are seeking treatment, to either get, no voucher-based option, or the voucher-based option, you can shift them, the people who get the voucher option, away from using the cocaine on the street to taking the vouchers. So it's essentially almost an exact clinical model of what the laboratory model was, like a clinical translation. But the key part of what we were talking about is the laboratory was a small n within subject design. And when you do the clinical intervention, you do a clinical trial using the rules of evidence that the larger community is going to recognize.
Right. So do you publish in JABA as well, GAB, or any of those?
Occasionally. I have published in both of them, and always proud to do that. But mostly I publish in the kind of medical journals and addiction journals.
And if somebody from one of those medical or addiction journals were to ask what you are, what your profession is, what would they say? Would they say psychologist? Would they say behavior analyst? What do you think they would say about you?
I think they don't know behavior analysts so much. And with my postdoctoral training, I would more likely be identified as a behavioral pharmacologist, especially in addiction journals, or, JAMA psychiatry, which you're going to get reviewers who are addiction. If you're doing work like I do, you're going to get experts in addiction. But I have to say, there's an article that I did in a story in the Associated Press on contingency management that I think just came out in the last week or two. So you could Google it. I haven't looked it up, but I did the interview.
I will.
And they described me as a psychologist in that.
Okay. I just wondered about that.
Yeah.
So what would you say to behavior analysts who were interested in this field, who were interested in learning more and getting more into this side of things, treatment? What would you recommend for them?
Yeah, I would encourage them to first of all, to learn their behavioral principles very well, and to especially, the extension to understanding human behavior in naturalistic settings, have fun with it. In graduate school, I went to graduate school with a couple people who also pursued addiction, Warren Bickel and Ken Silverman. And we had a lot of fun while we were in graduate school, just trying to always interpret everyday behavior in terms of the principles of behavior, giving each other, we would do it back and forth and argue, but we learned a lot. And we've all had successful careers in extending that work now into the field of addiction. So the way that we did it is we pursued postdocs, and I started out by mentioning my training, and I did a postdoctoral fellowship with a group that was behaviorally oriented, trained by a fella named Joe Brady. That there was a time everybody in behavior analysis knew who Joe Brady is. He was one of B.F. Skinner's collaborators or colleagues at Johns, but he was at Johns Hopkins when Skinner was at Harvard. I would encourage them to seek when they're finished their doctorate in behavior analysis, to seek a postdoctoral fellowship with one of the institutions that's behaviorally oriented. And so it's us, it's John, there's still a group at Johns Hopkins, at the place where I did my postdoc. When I say us, at the University of Vermont, there's folks at the University of Kentucky, at Washington State University, John Rawls group. And so you get mentored in that translation of moving from just behavior analysis, either like my dissertation was with preschool children and superstitious behavior, superstitious conditioning. I went from the model I used was a little preschool lab model where preschool kids would press the nose of a mechanical clown and earn, like, the nose would light up when the switch connected, like you would hear the lever on a bar press click, and they would get marbles exchangeable for stickers. And I went from there, like, finished my dissertation, defended it, and then went to Johns Hopkins, where I was supervising a methadone clinic and doing contingency management with opiate-dependent adults. So the principles,
a little different,
yeah.
But it's the principles of.
Yeah, it's the principles.
Right.
They translate across non-humans, humans, different age groups, different settings, all the things that were trained in graduate school. In my experience, they're spot on accurate. The thing that I think is less recognized in my experience is that there's receptive audiences, that people are interested in how we can address these major public health problems like addiction using evidence-based strategies. And behavior analysts have a lot to offer, but you've got to get a seat at the table. And you do that by doing careful work and understanding, like we talked about before, the rules of evidence, and having confidence that your principles are robust enough. So they have generality enough that you don't have to worry that you're going to violate some rule or something by doing a parallel groups design. But I think you are a little bit at risk when you do very small N, even if it's, rigorous in ways that we understand. Larger audiences are very skeptical as soon as they see a small N. And so you have to be mindful of that. But boy, my experience is that you can make, because we're trained to think in a particular way about behavior that's not that widespread. So that in terms of, looking for professional opportunity and a niche where you can make a contribution, that's how you bring a different perspective, and often you can make contributions that others won't make because they just aren't trained the way we are, which is good. They make other contributions that you can benefit from in your studies and whatnot, but you have your position to make unique contributions. And I after 37 years of doing it, I don't see anything that has changed my opinion. It's only strengthened my opinion about that.
Excellent. Yeah, I think too, with sometimes telling people, I mean, if they want to do the small end studies, you can start there too. And then when you find, when your hypothesis has been hopefully proven, then maybe it's time to move out. And then you're sort of satisfying both, obviously. Like, I had a statistics professor who used to tell me that if you and I run 10 miles a day and you run 0 miles a day, well, on average, we run 5 miles a day, but I don't run at all, so I get that part too. But I think if so if you're really like stuck on that thing, you could probably do both. You would start maybe with your small N, and then you could translate it into something that would work for other. Yeah.
Absolutely. And the way I shared like 2 different models that I used in the cocaine work, the laboratory, very well controlled, small N within subject, and then the parallel group trials. And you might think I did the lab first and the other one second, but it actually was.
Oh, you did it the other way around?
But they were kind of done concurrently.
Oh, gotcha. And that works too, though. I mean, you're still satisfying like both sides of your curiosity.
Absolutely. But I agree with you completely. You can start, I think the way you framed it is easy to understand approach or way of thinking about it. Start small, demonstrate for yourself that you're onto something, and then have confidence enough in the principles to not be afraid of different designs. And even the example you used from your statistician colleague is a good example, but it's not that complicated. Like if you have a group design and you're say the smoking during pregnancy, contingency management works much better than, orders of magnitude better than anything that's been tested in controlled trials. And there have been, last time I looked, maybe almost 100 controlled trials involving like more than 25,000 women across different treatments for smoking during pregnancy, and contingency management works better than any of them. But okay, so that's good and that's important. But the women that we get to quit with contingency management are mostly women who are lighter smokers rather than heavier smokers. And so that, that's important. But you can show that with your group design and with, a more detailed analysis of who's responding in the group design and this and that. It isn't that we don't get more heavy smokers to quit with the contingency management than the control condition does, but it is the case that most of the women we're getting to quit, or a larger proportion of the women we're getting to quit, are among the lighter smokers. But it's also the case that the comparison interventions don't get them to quit either. They don't get either the light or the heavy ones. So
so we're doing something.
It's just not, but I raise it not like as a limitation of the treatment so much, but as you can parse who's responding, who's not. And it's not like, they're all in one group. You can't understand, whether it's somebody running 10 miles or someone running 0 miles. Yes, you can.
Well, and he didn't take standard deviation too. Like, obviously there are other.
Yeah, that's right.
But I that stuck with me. I mean, that was, I think,
I
was in school in 2000 for grad school, so it stuck with me.
No, it's a classic. I mean, what you said is like a classic discussion, and there's a fella named Don Bear who passed away prematurely, but very prominent guy, and his specialty was research design. And when I started, and so it was all within subject. That's who at the University of Kansas, we all had to take his course on within subject design using Murray Sidman's Tactics of Scientific Research as our textbook. But when I started doing, I left and my postdoc started doing different kinds of designs, I felt like I had to go and almost like in the Catholic sense to do a confession with Don Baer when I first saw him at the next ABBA meeting. And he wasn't, like he said, these are different kinds of questions, so like that lab model is more like an experimental analysis, the study I offered around cocaine. And then the clinical intervention is more a test of what proportion of people you can get to change their behavior using different approaches. It's just a different question.
So it's exactly. So a different question would beg a different model. So
yeah, exactly. Yeah.
I agree. Well, this is wonderful. I don't want to take up too much of your time, but I thank you so much for all of this information. You're our first too. You're our guinea pig. So we'll see how it goes.
Wonderful. Wonderful.
We'll certainly send you.
I thank you for doing it. First of all, we have a postdoctoral training program here at the University of Vermont. So, and we've often taken behavior analysts we have them right now from the University of Kansas. We've regularly taken them from, and we have some from West Virginia, the Western Michigan, University of Florida, all the major, large programs for doctoral training and behavior analysts. Over the years, we've had graduates of all of them. They make wonderful postdoctoral fellows, and so we're always interested in people who have strong behavioral training.
Well, I'll put that out there too for people who are
wonderful.
Looking at, of course, we're the Virginia Association for Behavior Analysis, but
right.
They can go away for a little while and come on back.
Absolutely. That's the best outcome. So good. I really appreciate you doing it. And we're not the only program